Good evening. Today's topic for discussion is post-extubation respiratory stridor. Why are we even thinking about this topic as a separate entity for discussion is the NAP4 audit project, that is the National Audit Program, which was NAP4, which was held in UK, has dealt with complications which are related to airway and its management. So the NAP6 project basically deals with anaphylaxis, but NAP4 deals with airway and its related complications. So they have said that airway complications that occur during extubation carries a long-term morbidity and the risk of death during a perioperative extubation-related stress and loss of airway is more than that it would occur during an intubation. And ASA and colleagues have also found that the complication that occur during an extubation is having a greater risk and is occurring at a higher frequency than that would occur at the intubation. And ASA Closed Claim has also said that the majority of the claims that occur related to the airway has said that the occurrence is basically because the errors which happen during extubation rather than that of the intubation. Because we prepare so much for intubation, isn't it? If it's a difficult airway, we prepare the FOB and we do all sorts of airway manipulation and preparation that would help us secure the airway. But when we try to go for extubation and the rest of the stresses that would follow, we are not lethargic, but we have to have a staged approach to extubation also as compared to intubation. And this is from the BJ article, which is safe extubation after general anesthesia. So the airway-related complications carry a very notoriously higher incidence among the perioperative or post-extubation complications, wherein the airway irritation can cause cough and bucking, laryngospasm or desaturation, inadequate liver cell, and post-obstructive pulmonary edema and bronchospasm. These are all having an incidence ranging from 1% to at around 66%. So whenever the patient is having reduced level of consciousness and obtunded reflexes, breath holding, airway obstruction, apnea and hypoventilation, vomiting and aspiration, and laryngeal incompetence can occur. So these are all the airway related complications which can occur during an extubation. So notoriously, if the patient has got a cardiovascular problem also, say the patient is having a reduced ejection fraction or landing up in a perioperative myocardial ischemia, the patient may then throw a pulmonary edema, which can again present as perioperative respiratory distress. So the perioperative respiratory distress can contribute to perioperative or postoperative hypoxemia. The causes of postoperative hypoxemia can be a atelectasis, that is post-general anesthesia. If we have not used a recruitment maneuver in an obese patient or in whom there is already a lung pathology, in like put in a reverse Trendelenburg position, you have not used a ventilatory strategy that would define or nullify the atelectasis, then the patient may get a right to left intrapulmonary shunt, especially in patients who have undergone upper abdominal surgery or major abdominal surgery. And decreased functional residual capacity can lead to mismatched ventilation perfusion ratio. And as I've told, patients in congestive cardiac failure are at increased risk of perioperative hypoxemia. Pulmonary edema, may it be a post-obstructive pulmonary edema or fluid overload, or which can happen during a TERP syndrome. And alveolar hypoventilation, which happens because of residual anesthetic agents, drugs like benzodiazepines or opioids, and neuromuscular blocking agents when there is inadequate reversal. And there can be something called a diffusion hypoxia, which occurs when the nitrous oxide is used, and inhalation of gastric contents, which can occur during any major abdominal surgeries or which is taken as an emergency, or when they are taken at the full stomach in that case, or when there is an intestinal obstruction, or when there is a Roux-en-Y bypass, when you are applying a excessive positive pressure ventilation, and pulmonary embolism, pneumothorax, and increased oxygen consumption up to 300% can happen during shivering, and sepsis, transfusion-associated lung injury, ARDS, and advanced age and obesity. So these are all the causes of postoperative arterial hypoxemia. So the most common cause that would occur in the post-extubation scenario is the airway obstruction. So this is one of the notorious cause for post-extubation respiratory distress. The etiology can be multifactorial, and so many factors can coexist in one patient itself. So it can be either surgery related or patient related or anesthesia related. So what are all the patient related factors which can lead to post-extubation respiratory distresses? Any patient who is obese, has got an obstructive sleep apnea, in whom there is C-spine immobility, a history of head and neck radiotherapy, where the tissues are so much fibrosed and you are meddling in the airway again, and there is pharyngeal obstruction, may it be adenoid or tonsillar hypertrophy, any craniofacial abnormality like micronathia or rectopnathia, and neuromuscular disorders which has bulbar weakness, a patient with the peri-operative stroke, so in whom there is a bulbar weakness, or muscular dystrophy with a bulbar weakness, these patients will have increased risk of perioperative respiratory distress, and in whom there is laryngomalacia. And surgical factors can be where there is surgical related airway soiling, like tonsillar surgery, or when there is a oral intraoral cavity surgery, or there is an onco surgery which is happening like manipulectomy or any hemiglossectomies. So when there is blood and secretions which are pooling in the airway, when there is swelling, as when the patient is put on a Trendelenburg position for a very longer time for a total laparoscopic hysterectomy or lap-assisted vaginal hysterectomy, or any surgery which involves the pelvis, or any surgery which would happen in the Trendelenburg position or with a head extension, may it be carotid surgery or thyroid surgery for a long time. When there is a vocal cord damage, may it be in a parathyroid or carotid or in a thyroid surgery, when there is neck hematoma, and when there is a fixation of cervical spine, so when there is a reduced mobility of the head and neck. So these are all the surgical factors which will lead to any meddling in and around the airway region can lead to postoperative respiratory distress. And anesthetic factors would be reduced consciousness, impaired airway reflexes, and reduced muscle tone, and laryngospasm, a residual neuromuscular blockade, glottic edema, and airway device occlusion from biting or secretion. So suppose if the patient is put in a prone position, if not used a tongue bite, the patient is like out of anesthesia, neuromuscular blockade, and if they have bitten or the endotracheal tube, then you may land up in a patient where there will be inadequate ventilation because the tube is blocked. And residual neuromuscular paralysis is one of the notorious causes of post-extubation respiratory distress. It can range up to 20 to 40%. So the TOF, which is advocated before, was 0.7. As opposed to now, it is advocated that 0.9 or more than 0.9 is necessary for you to extubate. So though the patient may cough and generate an adequate tidal volume of TOF around 0.7, now it is advocated that 0.9 is important because pharyngeal muscles and upper airway muscles are so sensitive to your neuromuscular blockade. Though diaphragm and all the muscles of respiration may recover from your neuromuscular blockade, these pharyngeal and upper airway muscles, especially genioglossus and the muscles of tongue, usually get their full recovery only after 0.9. So it is advocated that you reverse the patient at 0.9 and take the patient out. Though many of the patient may be okay in the peri-extubation period, some patients may land up in recuriorization and TOF of less than 0.6 in the recovery room and may have respiratory distress. So this is maybe because of recuriorization which can occur. So nowadays they have found that rocuronium versus sugammadex combination works so well that these patients do much better. Again, TOF is necessary because inadequate reversal is again possible with sugammadex. So a TOF of more than 0.9, if you are able to find it with sugammadex, nothing like that. And residual neuromuscular blockade, you can be very sure that it doesn't occur. So when you are using intermediate muscle relaxants like atracurium or cisatracurium, it is necessary that you reverse with neostigmine as opposed to no reversal. Some people give no reversal, but no reversal group is no longer advocated because those patients who have no reversal versus reversal, the patients with no reversal actually get increased postoperative pulmonary complication as opposed to no reversal. So I basically give reversal to all my patients, may it be how much duration awaits. Since I've given a neuromuscular blockade, I have a habit of giving neuromuscular reversal to all patients with neostigmine if I have given atracurium or cisatracurium or rocuronium sugammadex. So if at all you are having an emergency situation in which you need to use a muscle relaxant after Sugammadex reversal, maybe the patient in respiratory